Hey, this is Dr. C. Nice to have you with me again today. Today I'm going to talk about the other half of the circulation. We talked about veins last time. We're going to talk about arteries this time. So let's get right into it. I hope you were able to understand some of the things that I tried to put into lay terms, into your language with the veins. And I'm going to do the same with the arteries if I can. Okay. You've heard the terms, the oxygen that the arteries deliver to all of the tissues in the body, and the veins bring it back to the heart. Very simple. The arteries can get involved with some pathology as well, and that is usually termed arteriosclerosis, hardening of the arteries. Now, what does arteriosclerosis really mean in your terms? Well, if you can visualize for me the artery, and the artery is composed of several layers. The innermost layer, right up against the blood that's running in the vessel, that innermost layer is called the endothelium. Endothelium. It's then surrounded by a muscular coat, the media, and then some tissue to hold it in, connective tissue on the outside. It's called the adventitia. So those are the three elements in an artery. Now, the arteries are different from the veins in that they have a lot more muscle in them. And the veins are also controlled by the nerves that attach to all the arteries. And so the arteries can contract and expand depending on whatever nerve is innervating them. And it depends on the situation, depends on the medication that you may be taking. In other words, there's a lot of influences on that particular artery. There are several different size arteries. The largest ones come right off the heart, the aorta and the big vessels that go into the belly. Now there are medium-sized arteries. Those are the ones going to the heart, the coronary arteries, up to the neck, the carotid arteries, and into the legs and arms. The legs called the femoral artery. Those are all medium-sized arteries. And then there's the very small arteries, just like there are small veins. Now, the reason I'm giving you all of this as a background, we're going to talk about some of the pathology, some of the things that can influence the disease in these artery blood vessels. Okay? Very good. So let's go on. Arteriosclerosis, how does that happen? What's going on with that? Well, the very first thing that happens is that inner lining, the endothelium, gets damaged. How does that get damaged? What's going on here? Well, normally, we think, at this stage anyway, that the damage occurs usually around a part of the artery that splits off. In other words, there's a little bifurcation, they call it. And a branch, it branches. And that causes some problems right at that branch area. That endothelial damage then can cause a leakage through that inner lining. And what usually will leak is that low density lipoprotein. That's that bad cholesterol. But that bad cholesterol is oxidized. Now, remember, we talked a little bit about oxidation in the past and what the development of free radicals, bad radicals, free radicals. And we want to eat good pro-oxidative stuff that's going to fight those free radicals. We want to have an antioxidant. Want to eat them. That's part of our diet. Also, might even be vitamins like vitamin C. I take vitamin C and vitamin D every day, just like Dr. Fauci. Only we came about it in different directions, but came to the same conclusion. We should have a little antioxidant, additional antioxidant in our blood vessels and in our system to help prevent some of these problems. Okay, getting off of my subject now. So, that oxidative LDL, low density lipoprotein, goes through that damaged endothelium, sets up a reaction there, an inflammatory reaction. So you can get some enzymes now liberated by platelets, liberated by white blood cells. And you may even get monocytes, other white blood cells, attaching to that area. And they convert into what they call foam cell macrophages in there. Well, the combination of the cholesterol, the low density cholesterol, and the foam cells become plaque. Now, you've heard of plaque in relationship to your teeth. This is not the same. The plaque in the teeth is bacteria, maybe a little fungus and all. Totally different than this kind of plaque. This plaque is fats and cholesterol. And then, because of an enzymatic reaction in that plaque stuff, you begin to get calcium deposited into that plaque. So that's why it's called hardening of the arteries, because of that calcium now that deposits into the wall of the artery. Well, that plaque over time enlarges. And so it gradually narrows down that blood vessel. Now, a blood vessel, as it narrows, can still carry quite a bit of blood. It's only when that blood vessel gets narrowed down to about 75 to 80% of its total circumference, then you begin to get less and less blood flow from that point on, going beyond that narrowed part of the artery. So that is the basic explanation of the pathology, arteriosclerosis, that happens in the blood vessels. So how do we deal with that? Well, first of all, symptoms. What sort of symptoms do you get? Well, we're talking now mainly about peripheral arteries, not the central arteries, not the big ones. So the middle-sized arteries, first of all, the middle-sized arteries. The middle-sized arteries that go down, for example, to the legs. There are 3 separate forms of symptoms that we can see depending on where that narrowing in the artery has occurred. You can get it up high in the pelvis, in the iliac arteries. We call that aortoiliac disease. You can get it in the thighs, which is called the femoral popliteal disease. And you can get it further down in the smaller arteries, going down into the calves. There are 3 arteries in the calves. So those arteries also can be involved with arteriosclerosis. So 3 separate types of symptoms. What symptom would you usually get? If you're not getting enough blood going to a particular muscle, for example, after that muscle works a little bit, it's going to start to feel the effects of not enough oxygen, and it's going to ache. That's called claudication. And so if you get a narrowing, for example, in that femoral popliteal area of the legs, and you walk a certain distance or exercise for a certain amount of time, you're going to begin to get cramping, sudden cramping in the muscles that are lacking the oxygen from that blood or the lack of blood. If, for example, you get it in the aortoiliac area, you may get some aching in the buttocks. You may get aching in the upper thighs. Same process, only different muscles involved. If you get it down low in those vessels below the knee, you may get it at the ankle or foot level. But it always occurs after a certain amount of exercise in those muscles. That's very classic. And you rest, and it gets better within minutes. So that's classic claudication symptoms. Now, as it gets worse, as it narrows even more, you may get rest pain. You don't have to exercise anymore. Now it's aching you if you simply lay down. Usually you get a lot of the symptoms when you're laying down at night. Rest pain. And then say that artery finally plugs up. Now you're getting very little oxygen. Now you begin to get some tissue loss. You may even get ulcers in the legs. So all those symptoms are all the same process, only because of differing areas of that artery that are involved. You can also get it up in the neck in the carotid arteries. The carotid arteries, as they again narrow, if they get to about 75 to 80% in circumference narrowing, you may get symptoms. And just like we get claudication in the legs, you can develop a TIA, a transient ischemic attack. Now this is just like a stroke. Just like a stroke. You may get a change in the face. You may get slurring of the speech. You may get weakness on one side of the body. The important thing about a TIA is that even though it causes symptoms that can resemble a stroke, the symptoms are gone within 24 hours, back to normal. So that's kind of a warning. Just like in the heart, you may get angina. That's a warning that there's not enough blood and oxygen going to the heart muscle, and it begins to cause pain in the heart, which is basically angina. So, similar symptoms in similar sized arteries and in the muscle that it goes to. So far, are we clear? Okay. So, depending on which region of the body is involved, you get symptoms in that particular area. So, what can we do about it? Well, what we do, first of all, we try to make the diagnosis, clarify it, see exactly what's going on. And we do procedure. I used to just do them in the office. It was so much easier for me to do them in the office. Nowadays, you get sent to the lab. You get sent for this test and that test. It runs the bill up into thousands of dollars. Why? Because the insurance companies wanted to have proof that you actually did that test. Nonsense. I could tell the people exactly what that test is going to show. But again, I get on my bandwagon about that. One of the problems about medicine nowadays. Okay, so what do? We do what we call an ankle brachial index. The very first thing we do with this whole artery examination is we feel the pulses. Now remember, I did a show on pulse, and it isn't just counting how fast that pulse goes. Also, you feel the artery. You feel it. Do you feel hardness there? Do you feel something different about that artery? Not a nice, even, steady pulse to it. It's harder, okay? What else? First of all, is it present or not? Maybe you may get a pulse on one side and not on the other. So I feel the pulses not only in the femoral area, which is in the groin. I feel right where that ligament is, right where the leg starts, right on that ligament. Then I feel below and in back of the knee, in between the two heads of the muscle that you can feel. And you can feel the popliteal pulse. And then I feel the two pulses down at the ankle. One that goes on the top and one on the inside, right under that shin bone, or not the shin, I'm sorry, the ankle bone that you can see. So there's two different pulses. So I feel all those pulses. Then I look at the legs. If I'm looking at legs, what do I see? Well, first of all, you need oxygen and you need blood for nourishment. So if you're not growing things like, say, hair, growing the nails properly, you may be lacking the nutrients, the glucose, and the oxygen going to that extremity, down to the legs. So you look at the legs. If that skin is thin and shiny, no hair, that means there's a problem with the artery inflow going into that leg. So it's up to you then to decide where is the problem. It's so simple observation, which unfortunately isn't done that much nowadays. But at any rate, let's go from there. I mentioned ABIs. What is it? ABIs, you're familiar with blood pressure. Okay. It basically is looking at the pressures, the blood pressures at different segments of the artery. So we can take a blood pressure cuff onto the thigh, a blood pressure cuff onto the calf of the leg. We listen, not with a stethoscope, however, we listen with a Doppler. The difference between listening with a stethoscope, where you hear turbulence, you hear the noise because it's going past a narrowing of the artery. The difference with a Doppler is that you begin to just hear little cells going past that ultrasound going through that artery. So red blood cells, white blood cells coming suddenly through, that is the we call a systolic Doppler sound. So we take that, we put the cuff on, first on the artery, on the arm, and you get a blood pressure up here, using the Doppler, listening down at the wrist level. Then you blow up the cuff. Usually we do both legs, both together. So you blow up that cuff onto the thigh, and you listen behind the knee to the popliteal. Listen behind. And so, depending again on the pressure that's coming through, you record that number. Then you blow up the calf blood pressure cuff. And you listen then down at the ankle level. You listen to both, because they most likely will be a little different. The higher one is the real pressure. Okay, so that basically will tell you the pressure in different segments of the leg compared to the pressure in the arm. You'd get a ratio then, arm to leg. And as that pressure goes down, if you have hardening of the arteries in the leg, that pressure is going to be lower, lower, lower. So if you can then take the ratio between the leg on the top and the arm on the bottom, as that leg pressure goes down, that number then becomes lower and lower and lower. And you can tell pretty much, depending on which level, which segment is involved. Very simple test, takes 5 to 10 minutes to do in the office, and you got your results. So that's basically what we do in the office. Now, you send people then for an arteriogram. Take a picture of the artery. So there's several ways of doing it. We used to do it, just put a needle in the artery and put some dye in, take a picture. Well, now they do a CAT scan, CTA, CAT scan angiogram, or they may do an MRA, magnetic resonance arteriogram. Basically, it's the same deal. You inject something into the vessel and you take that picture going down. Tells you where the narrowings are in that artery. Okay, there are various ways of treating it. It may be just putting a little catheter up the artery with a balloon on the end, go right up into the area that's narrow, blow the balloon up, crush that stuff to the sides of the blood vessel, and then you may or may not want to put a little stent in to hold that open afterwards. That's the most common treatment. This was before I was doing surgery. We would have to do a bypass. We take a piece of vein or maybe a Dacron material and bypass the blockage. Okay. Now also the carotid artery. What do we do with that? For many years, people were reluctant to do what they call endovascular procedure, which is putting that little catheter up into the artery right where the narrowing is, blowing it up for fear that they would break off material that could go to the brain. And it could happen. It could happen. But now they attach to the end of that catheter a little sieve at the end that will trap any material that gets broken off to try to minimize any damage done. And so now, I think probably equal numbers now of people who have that done with the endovascular treatment and open treatment. Open treatment. So basically that is what we usually do for treatment of arteriosclerosis in the arteries. Diabetics. Now, why is it so important to know if you're diabetic? Diabetics have a little different type of arteriosclerosis than the common non-diabetic. First of all, most of the narrowing occurs way down low below the knee, for example, in the leg, in the posterior tibial, in the perineal artery. A lot of the diabetics, 75% of them, have arteriosclerosis below the knee as opposed to non-diabetic. So location is important. Number two, the severity. It advances much faster in a diabetic, the arteriosclerosis, than in a non-diabetic. Number three, calcifications are different in a diabetic and in a non-diabetic. In a diabetic, the calcium can get deposited all the way around the artery. And we call that an eggshell type of calcification. It actually can crack like an eggshell. Of course, that makes surgery a lot more difficult, a lot more risky in a diabetic because of the fragile nature of the calcium in that shell around the artery. And there are some other problems that can occur. You may get really hard blood vessels in a diabetic, very hard, circumferential, right around the whole thing. So say I'm doing my ankle brachial index and I blow up the cuff and the artery's hard. You can't compress it totally. So when you're listening with the Doppler, the damn sound never goes away. It's there all the time. They're non-compressible vessels. That's a big problem because you can't tell then exactly how bad that narrowing may be unless you get that angiogram, that arteriogram. Also, the diabetics are much more prone to other cardiovascular problems. They may be at more risk for a heart attack, a stroke, than a non-diabetic. So those are issues that we encounter, and you have to deal with them. You have to deal with them. So what do I do with my patients who have hardening of the arteries? Say they're very mild, claudication. I put them onto a special diet. No fat, low cholesterol diet. Put them onto a statin. Try to get them to lower their cholesterol levels. We don't want more LDL going through that wall of the blood vessel. Exercise program. Very, very important exercise. Many of the people who have the worst arteriosclerosis are obese. In other words, their index, their BMI is generally above, say, 35 or 40. It's way up there. My BMI right now is 26. Not bad, 26 for an old man, But nevertheless, obesity is very, very important. So weight reduction, dietary control, minimizing the fat and cholesterol, exercise. Very simple, very simple. Try to avoid compressing type of clothing around your body as well. So they may wear diabetic socks, which are much softer sock, doesn't compress like a lot of the other athletic socks that are used. So we also have to control the blood pressure. Now, it's estimated 60% of people who are over 80 have high blood pressure. I know I have to take some medication to try to control it. Not a big deal, not a big dose, but hey, I'm on it. So you have to recognize it and not fight it. Take your medicine. Take your medicine. So those are the simple things that we can do every day. Certainly if you're a smoker, my God, you have to quit. You have to quit. Not only because of the nicotine that constricts the blood vessels, but also the carbon monoxide. Carbon monoxide takes over that hemoglobin molecule so oxygen can't get on it. Those two things are bad news. So definitely off tobacco. Okay, I think we've dealt with most of the problems, and I tried to put it into your language so that hopefully you'll understand it a lot easier. Give me a call here at the studio. Be happy to have any topic related to senior issues that you have, and I want to know about it. This is Dr. C. Have a nice day.